various gene polymorphisms have been looked into, and still, so there is an element of genetic or inherited dependence or progression of diabetic kidney disease. We look at the natural history of diabetic kidney disease. This is the normal GFR of 110 to 120, and that's what happens. The GFR gradually declines, and when it falls to less than 20, you start developing azotemia. And that's how the stages of diabetic nephropathy are defined. The microalbuminuria, then priming or the over macroalbuminuria, then the ESRD. And in 2000, what we used to define even 5 years back was by seeing the levels of the creatinine. But things have changed over time. And the KDOP, the stage 1, stage 2, I'm not going into great details. One thing you should, this stage 1 and stage 2, the silent stages. That means the estimated GFR is more than, is approximately 90. That's the incipient state, stage 3, which is microalbuminuria, and where the GFR begins to fall, and it falls less than 90. And that's where the GFR is between 60 to 90. And in type 1, it is, here the blood pressure, in type 1 it is increased, in type 2 it is normal, and the chronology, it progresses over a period of 6 to 15 years. And still the proteinuria is less than 300 milligrams per day. Okay. Then the overt nephropathy, that means less than stage 4 is between 30 to 60, yes, 30 to 60. So between 60 to 90 is in stage 3, and stage 4 is 30 to 60, and stage 5 is less than 20. So stage 5 patients are ESRD patients where the uremic and the GFR is less than 20, and this is associated with hypertension invariably, and the GFR is less than 20. And stage 4 is between 30 to 60, and the GFR is normal, GFR is below normal, there is macroalbuminuria, and associated hypertension, the protein excretion is more than 300. And so inversion, usually, the referred to nephrologist should not only begin when the creatinine goes up more than 2, this is micromoles per liter, but it should depend on the estimated GFR. The diagnosis, if it is in doubt, proteinuria occurs in the absence of retinopathy. Renal failure occurs without proteinuria. If there is nephrotic syndrome, nephrotic proteinuria, one should exclude other causes of nephrotic proteinuria, especially if the patient has an underlying myeloma or a hepatitis B, C, or in Western countries, HIV, or even other autoimmune conditions like SLE and stuff, or amyloidosis, or if there is unexplained hematuria, it should immediately refer to a nephrologist. And emergency states, preconditions where there is some worsening of the renal function, or there is hyperkalemia, or there is diabetic ketoacidosis or hyperosmolar states, poor blood pressure control, or the glycemic control is important where it needs to be referred to a specialist, and when renal artery stenosis is suspected, especially if you have a fluid or a small kidney on the ultrasound, or even on the doctor. Screening for diabetic kidney disease should be usually patients with diabetes should be screened annually for diabetic kidney disease. Initial screening for type 1 patients at 5 years, and type 2 patients straight away, and diagnosis. Measurement of urinary spot albumin creatinine ratio is now and it should be confirmed at least 3 months apart on 2 occasions. And measurement of the pale serum creatinine and estimation of the EGFR is important. So message is, don't look at the creatinine only, look at the estimated GFR as well. And if it is less than 60, it should prompt a refer to the nephrologist. Elevated ACR should be confirmed in the absence of ATR with 2 additional firstborn 2 specimens collected during the next 3 to 6 months. Screening, I'm not going into details, the same thing. Obviously, if the microalbuminuria is negative on the spot urine test, the rescreen in about an hour. If it is positive, reconfirm in about 3 months apart. And if it is positive, start treatment and work up GFR is determined by the usual NDRD formula, which depends on the serum creatinine age stage and the ethnicity as well. And that's what the stage 1, stage 2 more than 60, stage 3 is 30 to 60, stage 4 is less than 30, stage 5 is less than 20. Imaging or ultrasound is helpful, especially it is helpful to rule out any obstruction is there or not, and the size of the kidneys rather than anything else. It doesn't, you don't require an ultrasound of the kidneys to demonstrate whether the patient has a diabetic disease. Only proteinuria is important. The size of the kidneys is important. You've got to look at whether it's a symmetric or an asymmetric decrease in size. If it's a symmetric decrease in size, you've got to think about either a chronic glomerulonephritis or something going on. If it is an asymmetric decrease in size, you've got to think about a renal artery stenosis, and you try to go ahead with the doctor's study. Disadvantage when used for the to rule out differential diagnosis, no specific ultrasound features consistent with diabetic nephropathy. Referral for a renal biopsy really required, as I said, whenever you have urine sediments are strongly positive or you have a fact proteinuria. And management-wise, one is the prevention of diabetic kidney disease, then the adequate glycemic control, adequate hypertension control, optimal management of the pre-study stages and around replacement therapy. But I'll just focus on the glycemic control and a little bit about the hypertension. Primary prevention is before progression from normal to microalbuminuria. Secondary prevention is when microalbuminuria has already started and go over macroalbuminuria. And tertiary prevention is the reduction of diabetic nephropathy and progression of diabetic nephropathy to end-stage renal disease. And what is important, the DCCT, one of the landmark studies did show that the intensive therapy reduces the risk of albuminuria by more than 50%, and macroalbuminuria by less than 50%, 40% as compared to conventional therapy. Nice separation of the couple curves. That it was again demonstrated in type 2 patients, even at not only at 3 to 6 years, but also later on at 9 years duration, favorably intensively versus the conventional one. And this is the DCCT EDIC study in which the DCCT or the type 1 patients were followed up and later on after 20 years, and microalbuminuria was consistently more prevalent in the conventional treatment group, and the difference between the two treatment groups in the cumulative incidences of the new cases of microalbuminuria after the end of DCCT was still significant. And this is the separation from the conventional arms. Okay, and that's replicated down the years over even 10 years time. What's more important is sulfonylurea therapy, and sulfonylurea is the main metabolite in the kidney, and the action will be prolonged in CKD. And once the patient has got stage 3 CKD, one should use short-acting sulfonylureas and shouldn't use sulfonylureas at all. You can use glipizide, tolbutamide is not available. Other recent sulfonylureas which has got like glimepiride can be used but not the process of prohibition. The two common ones used is the glipizide and the glipizide because they're short-acting. And these are the ones which can be used even to patients who are undergoing dialysis. Other oral hypoglycemic agents, biguanides, caution if more than 1.4 in treated women and 1.5 milligrams per day if it's the male individuals. I think I'm running late, or quickly wrap up. In glitazones, especially since there is emphasis on either fluid overload or sodium retention, so one should take retention. Other OHAs, like the new ones, the DPP4 inhibitors, reduction of the dose by 50% when the GFR is less than 50, and by 75% when the GFR is less than 30. We do not have enough data with the increased biomatics, but no dose adjustment is necessary as far as preliminary data required. Alpha glucosidase inhibitors is not recommended in the PFS form 2. Insulin in glycemic control in diabetic kidney disease insulin dosage is significantly decreased with reduced creatinine clearance in contrast to the human insulin. Intensive therapy can notably improve glycemic control, and insulin analogs like Lispro has been recently evaluated in CKD patients with encouraging results. I think the time, hypertension control, we'll skip that because I think we are running out of time. Hypertension control, quite a few trials have shown the benefits of ACE followed by ARBs. The ACE especially in the type 1 diabetes and the ARBs in type 2. And you find that if you combine an ACE with an AR is more renal effective than either agent alone. And dual blockade of the RAS is more effective in reducing blood pressure and to some extent albuminuria. With evolution of the aldosterone antagonist, and found that the triple blockade might be beneficial even in control of hypertension, but worrisome is dual blockade is superior, even triple blockade is superior. But what is important is the risk of hyperkalemia and worsening of renal function in certain instances, and why ACE versus AR, the non-going into details, ARBs versus what is recently of late, in the past 2 years, it has been found that the ARBs, even the long-acting ARBs like telmisartan, the endpoint trials have not reduced the progression of ESR, progression to ESRD, and reduction in mortality actually. This has led to renewed interest on direct renin inhibitors like aliskiren, and it has been found that when you combine a direct renin inhibitor aliskiren with an ARB, the rate of worsening of renal function is improved. But what data we do not have an additional, and it is independent of the blood pressure lowering effect, but what data we do not have robust data on mortality. Again, as I said, addition of angiotensin receptor blockers, mineralocorticoid antagonism. We have a new agent like eplerenone available, mineralocorticoid antagonist, which reduces the risk of hyperkalemia, and that might be beneficial in diabetic kidney disease. I'm not going into details, a special population with that. What we need is a low blood pressure. What is most important is less than 130/80, maybe 130/75. But never go less than 110/65. Block the RAS with ACE or ARB, ACE in type 1, ARB in type 2, or a combination. Glycemic control not to less than 6.5%, but to less than 7%. LDL levels to optimal levels to less than 100, or possibly less than 70, because CKD is the most important stage where dyslipidemia management can also affect cardiovascular mortality. Protein restriction to less than 0.8 grams per day, and a smoking cessation. And with that, I'll stop here, and I'll be more than happy to take any questions.